Martin, you're on mute for a change.
Oh boy. I don't know what happens. I actually wait to unmute this thing. Anyway, it's something that the app does for me. Anyway, hello, and just wait. We've got a guest has just checked in. Oops, and there we go.
Professor.
And now we can kick off the show. Karibu, Professor.
Cool.
So, welcome to episode 22 of our Great Leadership live show, and thank you for making time to spend an hour with us and our guests this evening. Well, according to the American Cancer Society, when breast cancer is detected early and is in the localized stage, the 5-year relative survival rate is 99%. Early detection includes doing monthly breast self-examinations and scheduling regular clinical breast exams and mammograms. So in line with the just ended Breast Cancer Awareness Month of 2020, which began on 1st October and ended last Saturday, 31st October. We have in studio to talk about it, about breast cancer and early detection, Ann Waita, Salima, and Professor Wasike, and of course, what do we say? The brand himself?
English has failed you today.
Ilipotea leo. Yeah, but yes, karibuni sana.
Clearly.
Thank you for making time to be with us this evening.
Yeah. So shall we take off then? Thank you so much. Yeah, this is episode 22 of Great Leadership Live. We're going to give you we seem to have delays. We're going to give you the details of how you can get in touch with us on your screen as well. We're obviously on Facebook, we're on Twitter, and obviously you're watching this live. And as usual, we always ask our guests to let us know a bit about themselves. Whatever you saw in the poster is all well and good, but we were playing about this phrase, hearing it from the horse's mouth. We'd like to start then, as usual, with the ladies. Just tell us a brief background of who you are, what you do, and then we'll get off with it. We'll kick into the show with the questions. So I'll ask Salima, please, if you just tell us a quick bit about yourself.
Thank you. My name's Salima Kasaya. From Vihiga County. I am a teacher, specifically mathematics, geography. A mother of 4, 2 boys and 2 girls. My firstborn is 26, lastborn is 15 years. I am a breast cancer. I think.
Sorry, have we lost Salima? We seem to have lost Salima. And can I ask you to carry on then as we wait to get her back?
That's fine. Thank you very much for having me on the show. My name is Ann Waita. I'm a Bachelor of Science from the University of Nairobi, MBA, still from the same university, Strategic Management, and also Strathmore Healthcare Management. I'm a healthcare entrepreneur, specifically very passionate about cancer. And my passion started way back in 2005, and it is amazing how other people's experiences and my own experiences have actually defined my destiny. I'm happy to be here to be sharing.
Thank you so much, Anne. Professor, last but not least, please give us a big background about yourself, and then we'll get into the show.
Thank you so much for having me on. I hope you can hear me.
Yes, we can.
Yeah, so generally, Wasike Ronald from the Kakamega County.
Yes.
I'm Wasike Ronald from Kakamega County, did my undergraduate and postgraduate at both at the University of Nairobi. And now, after doing general surgery, looking at the situation where we are going in terms of caring for breast cancer, I decided to go to University of Alberta for a fellowship, a clinical fellowship in breast cancer management. And later on, I went to University of Emory for a scholarship for global scholars for breast cancer. So generally, I'm involved in teaching residents to become general surgeons, and also I'm also involved in taking care of patients in Eastern Central Africa and beyond. And I'm currently a PhD student in biochemistry. I'm looking basically at how vitamin D prevents the development and growth of breast cancer. Thank you.
Thank you so much, Prof. Actually, based on what you've just said just now, I'm going to throw this first question to you from the technical side of things. What to want to ask the question, and I think everybody needs to hear this properly, is what is breast cancer? First of all, what is breast cancer? Number two, is it hereditary?
Yeah, so breast cancer is cancer that affects the organ we call breast. So cancer generally is an abnormal growth in any part of the body. It could be the breast, could be prostate, could be colon, anywhere that is not under the normal control systems. And this growth has the capability of going somewhere else. And that's how actually it affects patients if it's not controlled, to kill them. So an abnormal growth in the breast that causes issues to the patients locally and beyond. The actual cause of breast cancer is not known, but when you're looking at the risk factors, there is a 5 to 10% chance of having familial or hereditary breast cancer. And this is when the genes that control, or the genes that help in controlling the development of breast cancer are mutated. There are several of them that the one with the high penetrance, or the ones that normally cause it, are called BRCA gene 1 and BRCA gene 2.
Okay. I'll come back. I'll ask you on the side what that is, but we'll come back to that question. Anne, I want to bring you into this conversation very quickly. I just want to find out from you. You said you've been in this from 2005. It sounds like you might have actually gone through a personal experience from the way you talked about it. But I wanted to ask, if you don't mind answering this question, what usually are the first signs of breast cancer? How can one detect it? Or in other words, how do you screen for breast cancer?
Thank you very much. Thank you, Prof, for the well-defined what is breast cancer. Basically, what's the first sign? There's no first sign because it presents different from different people. I will just go through the signs that you could see, and you probably have breast cancer. Cancer being uncontrolled growth of cells, you find that you might have a lump on the breast or thickening around the breast tissue. There's also the change in size. Usually, the size of your breast from when you got your first breast. So if the size changes, or the shape, or even the appearance of the breast, there's also the change of the skin color over the breast, such as dimpling, like an orange. The skin of the orange looks like. The nipple, if it is newly inverted, then it means there's also a problem. Discharge probably, and you're not breastfeeding. There's also peeling. If it peels, scales, that could also be a sign of breast cancer, or just redness or pitting of the skin over your breast. Those are some of the signs that you could be having breast cancer. And the next question is, how can one detect whether you have breast cancer? The first person to know is whether you have breast cancer is you, through self-breast examination. You should know your breast. And I always tell women, do not be ashamed of your body. The next person is your partner. For purposes of this discussion, I say your partner should be able to feel the lump, see the shape of your breast, and tell you things are not fine. You can also do a clinical breast examination. Usually women over 40, according to the American Cancer Society, should be going for a mammogram. And if something is unusual, then you will be sent for maybe a breast ultrasound or even an MRI, magnetic resonance imaging. I think if anyone has something to add,
that was great. I want to bring Salima into the conversation because it now relates to that aspect of screening and everything. And she had mentioned just before we got lost, Salima, you had mentioned that you have breast cancer or living with breast cancer. What I wanted to find out from you, because you've been through this or going through this, is what was the very first thing you actually did when you got the news that you had breast cancer?
The news came in gradually because I had done 3 tests. So the first and second test didn't show much. The third one, I went and picked my results, and I was to see the doctor. But this being a private practitioner, I had to wait for some time from 9 to 3 p.m. So during that wait time, it was a very difficult moment. But I decided to go to the Google doctor and find out what the results meant. I got to learn about it a little. It was not an easy experience because my son, who had accompanied me to go and get results, and the way I was looking at him, it's like it was really sinking hard in him. So that meant that I didn't have somebody to hold me. So it was me and me alone to look for some strength from within. So after learning a lot from the internet, I went in to see the doctor. I think whatever the doctor said, I was not listening because already it had devastated me to a great deal. So after he had explained, the next thing he told me that things are not okay. I need to go for surgery immediately because this had run from February to June.
Okay.
February is when I had my first test. April the 2nd, so this was June 2017 when I'm now being given the actual result. By that time, I think I had gone through all the signs Anne has said. The first one was the swelling, which came in February. Then followed in April the discharge, the bloody discharge from the nipple. And then the change of the breast, that was June. That's why the doctor felt it is urgent. I go to the theater. But being a Monday and he was telling me to get admitted on Tuesday, I felt it is too sudden. So I had to argue a bit about the admission.
Right.
But he was firm and he told me that I only leave his place when we have agreed. So I agreed to be admitted a week later. So that week was not an easy week. I tried to pretend during the day that I'm very strong, but at night I could cry a lot. Looking at the age of the children.
Yeah.
Because it's only the first one who was just doing her final exams at the university. This one who had accompanied me for the results had just finished Form 4 and was waiting to join university the same year. So crying was a lot.
Okay, I'm going to let you expound on that a bit more. I want to just come back in with Prof. Actually, I'm going to jump. Yeah, I'm going to ask Prof. The question about how many different types of breast cancer there actually are. Salima, which type of breast cancer were you diagnosed with?
Positive. 2 positive.
Okay, now 2 positive. So now I want to ask Professor to put that in context for our viewers by asking the question, how many different types of breast cancer are there? And I understand there's also aspects of grading as well.
Yeah, so when the specimen.
Yes, carry on, Prof. We can hear you.
All right. So when a patient comes to us and then we have seen her, we've examined her, and we've done some imaging and we send her for biopsy, then the biopsy specimen is taken to the pathologist. Now the pathologist, once she discovers that there are cancer cells, then has to give us the subtypes, what type of it is it. So the common one that we encounter is the one that starts in the ducts. So it's called invasive ductal carcinoma, Gr8Leadership. And then there are some that starts in the lobules that produce milk. You know, the ducts carry milk from the lobules. So it's called lobular carcinoma. So most of it, almost 80% of the cancers the patients will have will be invasive ductal carcinoma. And about 8 to 15% of the lobular carcinoma. And then there's medullary carcinoma and what have you. But to help in treatment now, we look at the molecular subtypes, like what she said, that she had HER2 positive disease. Generally, and then we want to see what is it exactly. So the normal breast tissues have estrogen and progesterone receptors to help them develop and grow, and also prepare for lactating. The hormones are produced by the ovaries. So normal breast tissues have those receptors. However, when we develop a swelling or a tumor inside the breast that is cancerous, then it can either have them or not have them. And in addition, it can have what we call a membrane receptor. It belongs to the HER2 group, HER2 new group. The HER2 new group belongs to HER2-1, HER2-2, HER2-3, and HER2-4. Now, the one that has much of interest in the breast is the HER2 overexpression. So all normal tissues have HER2, but it's not overexpressed. We call it at the level of 0 or 1. Now, if it is +2, then it means it's not conclusive. You have to do other tests to confirm whether it's positive or not, like the one she had. So, but obviously, if it is given as +3, then it's obviously positive for HER2 overexpression. Now, there's another type that doesn't have any of those receptors. Doesn't have ER, that is the estrogen receptor, doesn't have progesterone receptor, and it's not HER2 overexpressed. So we call it triple negative. And again, triple negative is divided to make things very difficult. It's divided into 4 groups, but I'm not going to go into those steps. Currently, in terms of clinical approach, we only use those 4 molecular subtypes to make the diagnosis and also to help the patients in their treatment.
Yes.
Yeah, so I think that's in a nutshell. That we could take the whole day talking about subtypes, but that's in a nutshell, that's what it is. But now, having said that, in terms of prognosis, the one that has ER, the one that has estrogen and progesterone receptors, because it's closer to the normal tissue, it is more favorable in terms of outcome. The one that has HER2 overexpression, it tends to be more aggressive, and the one that doesn't have any of those receptors then also tends to be very, very aggressive.
Okay.
I think there's another question you asked about grading. Now, grades are actually when they start. Yeah. So when the histology report comes, there will be grade 1, 2, or 3, and this now is based on, if you look at the cancer cell, how does it relate to the original breast tissue cell, or the colon or prostate? So if it is very closely associated with the original cell, it's called grade 1. If it has 50-50, let's say 50% of the cancer cells are different from the original cell, and 50% are close, then it's grade 2. But if they are completely different, then it's grade 3. Now you can tell from that the grade 3 will be more aggressive in terms of how it behaves in the patient. Now there's the other one of staging, which we'll discuss later, because there's a difference between grades and stage. But patients ask those questions. We'll discuss later. Thank you so much. Yeah.
No problem. I just want to ask, I'm going to come to Anne. I just want to ask Salima very quickly. The grading that you had for your breast cancer was grade 3, isn't it?
The grade was grade 2, but stage was
grade
3B.
2.
Yes.
Okay. Oh, the stage was 3B. The grade was 2 and the stage was 3B.
The grade was done immediately.
So stage is different from grading, just to the wrap.
Grading, yes.
So let her go ahead.
Sorry, Salim.
So the grading was done immediately after surgery. Then the staging was done after the sample had now.
Okay.
I was saying that the grade was done immediately after surgery. Then the staging was done after now the sample had been analyzed. So the grade was initially grade 2, and then the stage was stage 3B.
3B. Okay. I'll come back. We're gonna try and explore stages later on if we have the time. We need to actually. And I know you're sitting out there feeling like you're in the wind. You're out like the forgotten stepchild. I wanted to ask you, and especially now, this goes back to what Salima said in terms of how she was crying and how she was looking at her children and saying, okay. But from the aspect of when one is diagnosed with breast cancer, is it often recommended then to engage a mental health professional at that same time as well?
Thank you. Well, for purposes of my comfort, I would not want to bring in the mental health professional. I would want to call them psychologists, but not, yes, psychologists. Normally, what we advocate is that a patient should have a navigator. See, the way Salima went alone with her son, you alone. What you need is somebody to walk with you, because most of the times when you're talking to a patient about their disease, they block. I mean, cancer is not easy, so the blocks. It's always good to have somebody that works with you. Could be your confidant. Okay, to involve a psychologist if you feel you want to, but it comes at a cost. Someone will navigate you, because you realize that the cancer staging takes a long time. Like Salima says, from January to June. This is not a one-day affair. So somebody to navigate you, tell you where you're going to see, which doctor you're going to see, where you're going to do your x-rays, your CT scan, where you're going to do your surgery, where you're going to do chemotherapy, what happens from here, what are the costs. Yeah, that is very, very important. Plus also, you realize being told you have breast cancer and you're looking at your children, being told you're doing chemotherapy, you're going to lose your breast, you're going to lose your hair, you're going to have mood disorders, you're going to probably even, you're looking at death, relapse, a lot of things. So it's very important. Thank you.
Thank you so much. And Dr. Ari, I want to come to you and ask this question. How is breast cancer typically treated? I think a lot of people tend to go, there's an option of either removal, there's chemotherapy and those kind of things, but just expand slightly on in terms of how you actually manage it or how you treat breast cancer.
So actually, in terms of treatment, the first thing after the diagnosis has been made, what we have done here routinely in Aga Khan University Hospital, which I started in 2008, is that we have a multidisciplinary approach, because Wasika alone as a surgeon and when medical oncologists alone, they're not sufficient for Salma. We need somebody, we need a group of doctors plus nurses and counselors to sit down and say, what is best for Salma? And that's why it's important to have a multidisciplinary. So you have the pathologist, radiologist, the medical oncologist, the breast surgeon, the radiologist, and then the nurses and the counselors. So that's the first stage. Now we decide that we are going, this patient has these particular characteristics. After staging, that's the staging is very important. So in terms of staging, before I go to the actual management, we have stage 0. Stage 0 in the earlier days, about 30 years ago, was rare to find because then we didn't have screening. But now with a lot of advanced digital mammographic screening, we are able to detect the disease before the patient and the doctor can feel it. We call it stage 0. The only thing that the mammogram shows is architectural distortion or asymmetry, and then sometimes calcium deposits, what they call microcalcification, which are suggestive of cancer. And usually this kind of cancer is within the duct, so where it started, so it's called ductal carcinoma in situ, and that's why it's called stage. That does not have the capability of moving from the ducts or the lobules to go somewhere else. And if it's done well, if it's treated well, it has a 100% survival rate in 5 to 10 years. Now, having said that, the modalities that we have available for treating breast cancer, if it is stage 1, that's where it's confined to the breast. It has not gone to the local lymph nodes or it has not gone elsewhere, and is less than 5 centimeters. We'll offer the patient surgery. And surgery can be in two ways. The first one is we do what I've been doing for the last 15 years, which I call breast preserving surgery, or breast conservation surgery, that was started by Professor Bernesi of Milan in 1969. But now we are practicing it here. But you see, the option of mastectomy stage for stage and for breast conservation must be equal in terms of the outcome, the breast cancer disease outcome, because that's the main focus for us. Okay, we want to save the breast, but it's also important to know that the patient's life is so crucial. Now, for you to do breast conservation surgery, again, it requires teamwork. You require a pathologist that is going to look at the specimen, intra-op, and decide that you have removed everything with clear margins. At the same time, if you're also doing sentinel nodes for the lymph nodes, he or her has to look at it and say, yes, the lymph node is positive or negative, unlike when you are doing mastectomy. And then once you've just removed part of the breast, the next stage is that you have to do radiation therapy, and that's what Anne does most of the time. I've been sending our patients. I'm happy to see her today. So the radiation therapy is part and parcel of breast conserving surgery to sterilize the breast so that the cancer doesn't come back. Otherwise, if you don't have the pathologist and the radio-oncologist, then you cannot do breast conservation. Or if the patient does not have the criteria to undergo radiation therapy, then you cannot do breast conservation. So in terms of surgery, then we are talking about breast conservation surgery for early breast cancer or a mastectomy. Now, the final person to decide that is the patient. We have to take into account the patient's preference for her treatment. We cannot force it just because it is in the books or we know about it. So the patient has to comply, of course, with informed consent. The second one, as I've already mentioned, in this situation is that we need radiation therapy. Now, radiation therapy is used in 3 circumstances. The first one is when you have not removed the breast, which I said breast conservation. So to make the outcome similar to mastectomy, then this patient after 1 month or so will need to undergo some sessions of radiation therapy, which Anne will be discussing, I think, upfront. Then secondly, if the size of the tumor is more than 5 centimeters, and even if you do mastectomy, to give this patient a better outcome of no recurrence or limited recurrence, she will require radiation therapy. The other third one is if the lymph nodes in the armpit, more than 3 of them are positive for disease, which cannot be cleared by chemotherapy. So then this brings me to the other modality that we have for treating breast cancer, and that's chemotherapy. Chemotherapy could be looked at in 3 ways also. We can just use the routine chemotherapeutic agents that we used to use before. And that is a group of, we don't just use one, we use at least 2 or 3 to treat the patient, and these patients routinely get 6 to 8 sessions if they require chemotherapy. The other component of this chemotherapy, because we give it by system, we put it either in the blood or the patient can swallow, is systemic therapy. Then we can give hormonal therapy. For example, we're discussing the idea that the patient has ER/PR positive disease, hormonal receptor positive. They will require, after we've done everything, surgery, chemo, they will require 5 years or 10 years of hormonal therapy where we give tamoxifen or letrozole for that period. And the third component is what we're now describing as targeted therapy. She had HER2 positive disease, so we have to use specific antibodies that target that HER2 positive disease, and that's called targeted therapy. We also have it in hormone-resistant disease. We call them CDK4 and CDK6, but those are the new things, are still experimental, and so that's what is called immunotherapy now. So I've discussed normal chemotherapeutic agents of many years and years ago, discussed the hormonal therapy for hormone receptor disease, and then for targeted therapy for specific diseases. So that's basically the modalities that we use to treat patients with breast cancer. Now, if a patient comes with a bigger tumor, we might say that we are going to shrink it. So we give her chemotherapy upfront. It's called neoadjuvant chemotherapy, and then we do surgery later. The other similar scenario is if a patient comes with stage 4 disease, which has already left the breast and gone to the other parts of the body, it will be unfair to the patient to do surgery to control local disease when it has already left. So we normally give them chemotherapy, and this could be chronic chemotherapy use, and it's also called palliative treatment. For this patient, she had stage 3 B disease, so I think she needed to do chemotherapy up front before surgery. But maybe she went in a place where we don't have multidisciplinary approach. But I think whatever they did, surgery and then chemo, that's okay. Thank you so much. Sorry for talking so much.
It's relevant information people need to know either way, so there's no need for apologies.
Yeah.
I'm going to come to you because Prof was referring to you in terms of the treatment.
But Anna was asking a question.
Yes, Prof.
She was asking about brachytherapy, whether there is in breast. Yes. So localized breast, like mammoplast, or we can still do it when we do partial radiation of the breast, which is not done here locally, but we are going to start it. So mammocytes and other rods can also be used, like in the target study in the UK, instead of doing beam radiation. That's what she was asking. But she's the one to explain to us. She's the one to explain to us about all those. Thank you. Thank you so much.
Okay. I'm going to try and see whether we can make it a bit less technical and go more into the personal side of things. And I'm going to ask you in terms of about risk factors, but I actually want to bring you in a different kind of way. Salima has gone through treatment for her breast cancer, which Prof went into detail about. I want to ask two questions, one to Salima and then the other one to Anne. Salima, for you personally, basically, what are the side effects of that treatment been? And then, Anne, I'll come to you in terms of the broader spectrum, in terms of what people typically go through in terms of reactions to the different types of management or treatment of cancer. So, Salima, I'd like to ask you, just give us from a personal perspective, how that treatment has actually affected you, or the side effects.
I've gone through 3 treatments.
Mm-hmm.
So the surgery, since the cancer had gone to the lymph nodes, that has made the movement of the arm quite difficult, especially for my profession being a teacher. Writing on the board, marking books has been an uphill task. Then lifting items using the same hand.
And we lost Salima again. Okay.
Yes, we have.
When she comes back, I'll ask her to continue. But okay, she's back now. But Anne, you want to just be taking that quickly as I wait for Salima to come back online?
Okay, so I can see she's back online. I'll just go generally on what patients go through.
Mm-hmm.
Of course, if it's surgery, there is a wound to take care of. Some people heal very quickly, others take longer, depending on your immunity. Then there is, if you're doing chemotherapy, there is loss of hair. There is nausea. Not everybody, but most people. You have got long-term effects like hot flashes. You will also have probably just fatigue. You get tired because chemotherapy or radiotherapy it's supposed to be killing the cancer cells, but it also kills or injures the normal cells. So you get fatigued. You might have pain on the breast. What Salima talked about the heart swelling is called lymphedema, which comes because of the surgery. And Prof can expound on that. You also have lots of, the sex drive is lowered also during the chemotherapy because of the cancer treatment. What else? There is also something called chemo brain. You find that most patients forget a lot because we call it chemo brain because of chemotherapy.
Right.
Other effects, yeah.
Okay, so this is what you've experienced, at least from a broader perspective. Sorry, Prof, yes? Prof, you're on mute. Unmute your microphone.
Yes.
No, I thought you were adding on to something that Anne was talking about.
Oh, she was talking about the side effects of undergoing treatment. They are local and then systemic. Yeah, they are local and then systemic. Okay. She has described mainly systemic problems, but for surgeons, because we cut locally, they are also local side effects. The commonly encountered is formation of. Okay, so do you want me to continue?
Sorry to cut you off. Let me just ask Salima, because we tend to be losing her. So Salima, we had from Anne what the typical kind of reactions or side effects of the treatments for cancer, breast cancer can be, but I was trying to get it from your own personal experience in terms of what you said. You said you had a problem with the arm, and Anne had touched on the aspect of lymphedema. We'll try and expand on that a bit later on, but I want to hear from you personally in terms of what you've been going through. No. Okay, we've lost her again. Let me change gears a bit. I'm going to ask Prof this question first, and then Anne, I'm going to come to you on a different thing. Professor, and I know a lot of men are sitting there saying, yeah, my wife and her breasts, and you see all these problems. But do men get breast cancer?
Yes, we also have breasts, but unfortunately, they are very small residual breast tissue. However, there are some conditions that might lead to enlarged breast, which we call gynecomastia. Now, 30% of men have gynecomastia. Gyne, of course, means woman, and mastia means breast. So men who have woman-like breasts, we call it gynecomastia. But that alone is not a predilection for developing breast cancer. In men. I've discussed this topic and it's still on YouTube in 2013, but let me repeat it, that men also develop breast cancer. In the last 5 years, I've seen about 15 men, including 2 of them in the last 3 months. So yes, to answer your question without putting the story around, yeah, men develop breast cancer. Yeah, they do, because they still have breasts.
Would there be a stigma attached to it or anything? Because I
think that for the young man who was 28 years old, he kept insisting that his friends had told him this is just gynecomastia, it comes in puberty. Remember when we were breaking the voice, before he broke the voice, some of us developed some large breast on one side or another. So because he had a lump and he was 28, his friends insisted, and even his wife, that this is his girlfriend at that time, that this is not cancer. Even if the doctors are saying it's cancer, it's just gynecomastia. I've read about it. You know, the way Dr. Kukul has done. Little knowledge is worse than having knowledge. So there's a lot of issues. And then the other thing is that now even breaking the news, like the one I saw 2 weeks ago, is an old man, 64 years old. He had difficulties even telling his wife that I have a lump in my breast. He was just wondering, how do I break this? And this, because of that, most of them come with, and you know, we don't have much of breast tissue, so it's very close to the skin, very close to the muscle. So the probability that a man will come with advanced disease is much higher as compared to women who have bigger breasts. So yes, we have this, but it's a very low. You know, the estrogens, which we don't have much, are kind of, because of the androgens, tends to protect us. So 2 things: the small breast tissue and our male hormones tend to protect us against getting it as much as women do.
Okay, thanks, Professor. Salima, welcome back. I have a question for you. I'm going to throw you away. I just want to ask Anne a very quick question. In terms of what she said, it triggered a thought. You said about treatment creating lower sex drive. And there's a question I've been seeing a lot in terms of another aspect of the scariness of breast cancer. Does breast cancer treatment, the treatment of breast cancer, affect one's ability to have babies?
Very interesting question. Yes, lowered sex drive doesn't mean that you cannot conceive. Eh? You might have 1, 2, and you get a baby. Oh, yeah. Yeah, some treatments for breast cancer, yes, might affect the woman's fertility. For example, chemotherapy for breast cancer might damage the ovaries, which can sometimes be immediate or delayed. So sometimes some women actually conceive after the treatment. So it's not all doom.
Okay.
In
Salima,
addition,
yes,
in addition to
carry on,
that,
Professor. Yes,
Mr. Chair. So going forward, for women who are young and they have their breast cancer, the best approach is to try and preserve their eggs. So now we have, even as specialists, we have trained 2 of them here, who harvest the eggs so that before the patient undergoes through chemo, then they harvest and keep them in the fridge so that it can be used later when they have healed. Patients, particularly those who are above 35, are unlikely because what it does, chemotherapy can cause castration of the ovaries so that they actually get early menopause. So in this situation, the best thing is to harvest the eggs and then keep them so that later on, when she has recovered, then we can start the story again. But young ones below 30 years or 25 years, whom I've treated, they tend to recover. The ovaries tend to recover, particularly if we protect them with some hormone that protects both the pituitary, the one that controls the ovary ovulation, and the ovaries at the same time. We call them something like salad eggs. I don't want to go into details. Right. You say it being so technical is not useful to us, to the audience. Thank you.
Yeah, thanks, Prof. Just to add on to that, we also, during radiotherapy, we also protect the ovaries a lot so that we don't damage the ovaries for future use.
Yes. Thank you.
Protecting future generations.
Yes.
Salima, good to have you back. I just want to continue the conversation I was having about what have you experienced personally as a result of the treatment that you've been going through for breast cancer?
Come up again.
I'm saying, what have you personally experienced in terms of the side effects of the side effects of going through the treatment or management of cancer? What have you personally experienced?
Personal experience is that tiredness or fatigue. Then there's the pain, joint pains. They are very severe. At times, sleeping becomes a big problem. Then the side of operation also, sleeping on that side is a bit difficult. Then apart from the few, during the treatment, there was that bit that Anne has exhausted, the lack of appetite, then the hair loss, then the skin color also changed. I think I became very dark, and sometimes the skin would peel off.
And then were you?
Yes.
Okay, from that perspective, shame because Salima, there you are. So how did that make you feel in terms of being able to be social with other people, or emotionally, how did it affect you?
Emotionally, it made me a bit shy, especially after the breast was removed and the wound has not healed. I need to go back to school because after a month, the wound had not healed properly. So I opted to using scarves to cover myself because I could not put on the bra, I could not put on the artificial breast. Then there are times you meet people and they're asking, hey, what is wrong with you? Because the skin is not the normal skin they know. It's very dark, and sometimes people say it on your face. It is so demoralizing. The hair is gone. Sometimes even the wig cannot be held on the head. Sometimes you put it on and it falls off. So at times you are supposed to remain bareheaded, and the looks that people give sometimes are not the best. So emotionally, it can also eat up. And maybe the only thing I did is to understand myself more, because I realized as I walked this journey, people cannot understand you. It's you to understand yourself. Then the other thing I also learned during the journey, it's good to be patient. especially when looking for medical care. There are times you go here and you're told, move to another facility. We are not giving this service today. Wait for a week. So patience, it doesn't come that easily, but with the time, it develops. So without the much support.
Thanks, Salima. That's good. Yeah, sorry. Yes, carry on. Yes.
I'm saying without much support, some people lose the fight on the way. Many people have lost the fight on the way because the inner strength is not in, and sometimes you look for other support which is not forthcoming.
Okay, that bit we need to. I wish we could expand on that. I'm just looking at the clock. I'm looking at the time. We don't have enough time left. Anne, I'm going to come to you, then I'll come to Professor. There's something that we mentioned at the beginning, and there's all these aspects of staging and everything. But how much does it cost to actually do screening?
Okay, of course, like for self-breast examination, it costs zero because you do it yourself.
Yeah.
And that is most of the time that you pick it from there. Then you can also go for a clinical breast examination. That is not expensive. It's probably between 3,000 and 5,000. A mammogram, usually in October, most hospitals have lowered the charges. But like now, this is November, it will cost between 4,000 to 10,000, depending on where you go. If you need a breast ultrasound, it will also cost between 4,000 and 14, depending on where you go. An MRI will cost between 15,000 and 30,000. And the beauty is to know that NHIF actually pays for MRI. There's something called a biopsy, which maybe Prof could expound on how much it costs, because it costs, I think it depends on is it ultrasound guided, is it CT guided, I think Prof could pick up from that and tell us how much a biopsy may cost.
Okay, thank you very much.
Prof answers that question.
Yeah.
Sorry, Prof, before you answer that question, I've got another one that I want to ask you as you're getting that ready, getting that answer ready for that. It's something I wanted to find out in terms of, now this is the divide between the third world, first world, etc. So the question is there a certain prevalence of breast cancer, say, in the first world versus the third world? Does it affect a particular social class more than others?
So I'll start with what Anne was saying, then I'll come to that, because it's kind of it's a political, social, economic question. So let me start with the easier one. Yeah. So in terms of screening, I think that when we actually talking about screening, we're actually talking about a test that is able to pick up disease before the patient can feel it, or the doctor can feel it, all right? So then self-breast exam becomes not so useful in terms of screening, and also the doctor examining you without sending you for mammogram, ultrasound, MRI also becomes less useful, because by the time you develop a lump or you see the symptoms, I think it's already too late. What we want is to catch the disease before it becomes stage 1 or 2 or 3. And therefore, that's why the screening tests that have shown improvement in outcomes and also that has saved lives is the mammogram, the screening mammogram. Unfortunately, most of our patients are below menopause, below 40, so they cannot generally undergo screening mammograms. So and then we go back to what Anne was talking about, examination, ultrasound and stuff like that. However, in high-risk patients, those who have genetic or familial breast cancer, then the screening doesn't then lie on mammogram, it becomes the MRI. The MRI is more sensitive, but you know that when it's highly sensitive, then the specificity becomes a problem. So it can pick up a disease that is not clinically important, and then now the doctors are left there. What do we do with this patient? So that's what I wanted to talk about screening. And now for October and November, for the many years we've in this hostel, we always give a discounted national, like now it's 3,000, I think 200 for 2 months for mammogram screening, mammogram and stuff like that. And we're also doing pap smears and PSS for pap smear and PSS for men. So you're welcome to come and take advantage of these 2 months. The October is already over, but we can receive people in this month and do the screening. Now, for a long time, the third world was bedeviled by infectious diseases, HIV, malaria, and tuberculosis, and with poor nutrition. Okay, not really poor nutrition, some kind of malnutrition that left people with very low BMI. For example, I have some friends who are obese now, and I'm also tending towards there. But if you go to morning, people walking to industrial area, or go to Madare, you will not see this pregnant men there. Everybody is lean and muscle and bone. So social economic status, in a way, gives you for example, if you're looking at communicable diseases, and that's just not cancers, looking at hypertension, diabetes, and cardiovascular disease, people in a low socioeconomic status are likely to get maybe tuberculosis because they're not feeding well, so their immune is a bit low as compared to cancers. Now, so generally, even up to now as we speak, the number of cancer patients in the world are more in a high economic status place, with people who have issues with alcohol intake, they have issues troubling with obesity and overweight, people who can eat and throw food away. So still up to now as we speak, even if you compare Kenya to the US, you see that the Kenyans have less breast cancer as compared to the US population. But because of the health systems, the deaths from cancer are less in US or Western Europe as compared to us, because our patients come with very late disease, although the numbers are low. So that is, you see, in terms of treatment and in terms of development, that's the politics I can bring in. But I think they are actually supported by facts that you can access on WHO and whatever it is.
Yes.
So to prevent cancer generally, I know maybe you'll ask at the end. I think you'll ask at the end. I'll tell you what,
yes.
what it's all about. Yeah.
Okay. I'm looking at the time. I want to ask Salima this question. The fact that you are proof that people can live or can manage breast cancer, what would you say from a personal perspective? What would you say to those people who hear the word cancer and then think it's a death sentence? Because you heard it and you reacted the way you did, but some people hear it and think it's a death sentence. And what would you say to those people who are too scared to try and get screened in the first place? Salima?
I think I'll tell them that so long as you follow the doctor's advice, you can still prolong the life. I remember this is HER2 positive, which Dr. said is quite aggressive. But having gone through all the treatments, I think I'm now strong enough and I can still push on. So it is always good to see the doctors and keep to the treatment schedule. Each time you are advised to take your chemotherapy, take it on time. All the radiotherapy sessions, take them on time. And all the follow-ups, they really assist. And then with the time also, the doctors keep on advising on how you should eat and how you should keep fit. So cancer is not a death sentence as many of us have thought before.
Right. Okay, thank you, Salima. Now I want to ask, Dr. Professor, you had mentioned about the aspect of prevention. I want to go then to the whole aspect of October and what happened in October. And I'm going to ask this question, then Dr. you can jump in, Professor, sorry, you can jump in. I want to ask Anne this question. Breast Cancer Awareness Month came to an end on Saturday, yes? This weekend. What was this year's theme? and how did we as Kenyans get involved in terms of, how did we create awareness, and how did we then, I think Professor will come in from that perspective, how did we teach people about prevention?
Thank you. This was a very unique year because of COVID, of course. So there are a lot of things that did not take place. But this year's theme was give hope, save lives. The whole idea of early detection. Usually there are very many activities that are done. All hospitals, I know, all hospitals to give discounted rates for screening for all the cancers that can be screened. In terms, like, I need to say this, that we run the Consolata Madari, and we're also having a cancer awareness programs, and you're doing all the tests there for at reduced cost. But I must say that in terms of the fundraisers that have been done, like, I know there is a foundation called Tukuza that usually has a choir that raises funds to pay for patients, the NHI or treatment. This was really done under very strict condition measures because of all the COVID. So in terms of awareness this year, it has been overshadowed by COVID. But for Prof. I and many other people, for us, cancer is every day because you see it every day. So I would urge Kenyans, don't just wait for October to go for your breast cancer screening. You can do it any other time. Love yourself.
Thank you so much, Anne. Wonderful words. We wanted to talk, Professor, you wanted to talk the aspect of prevention. Did any of that, I mean, it must have come out during the Breast Cancer Awareness Month, but typically, how do you then advocate for prevention?
I think that, as we have always said in medicine, prevention is better than cure. But what has happened in the last 50 years or so since the curative medicine came into being, I think we've been addressing a lot the methods of how to treat the disease once it has occurred. So for non-communicable diseases where cancer is one of them, and cardiovascular, of course, you know that cardiovascular diseases kill more people than any other disease currently, particularly in developed countries. That is catching up with us. I've seen people with pulmonary embolism, with strokes, even below 30 years. And then a lot of hypertension, a lot of diabetes mellitus, and then cancer, as we've said. So I think that if we address only three things, which is possible, but they're not easy, then we're going to prevent all those things I've said. One is that we must eat well. We must eat well. We must eat a lot of vegetables and a lot of fruits, which has minerals and vitamins. You know, cancers we are talking with right now with you guys, the cells are trying to refuse to comply with their neighbors and the communication that, man, you are old, die off, and some refuse to die off and they become cancerous. But if you have vitamins that have antioxidants like vitamin C and many other components, then they actually they improve the function of the natural killer cells which we have in our immunity, and that in itself then prevents the cancer to develop. The cells that are trying to misbehave are actually handled. Number two, so diet is very important. Let's be less on smoked meat, roast meat, fried meat, whatever meat or whatever. Let's be low on that, but be very high on green vegetables and yellow vegetables plus fruits. Number two is that when you look at obesity, a simple mathematical problem, weight is equal to food minus movement. Okay? If you reduce the food and balance the movement, you'll be fine. If you eat food and move more, you'll be fine. So that's so. We need to exercise, and doesn't mean you have to go to the gym. You can, for example, have a smartphone, a smartwatch, which tells you, like now mine has told me that I haven't moved for, I still have 200 steps in this 1 hour that I've been sitting here. So if you have such a reminder, you can walk around and go say hey to your friend. So movement, any movement, and the aim is that you have at least 10,000 steps a day, which is not easy because the average is 3,000 to 4,000. So exercise is important. The third thing that can prevent all those conditions I said is sleep. You know, people underrate sleep, and you know, like now most of people are self-driven. They spend a lot of time working on some programs, and then after that they go and have a drink, and they watch the TV until morning. They have only 2 hours. The body recovers and it regenerates only when you are asleep. So food, exercise, and sleep. Very important, at least 6 hours of sleeping. And then for you to sleep, you have to be tired. Otherwise, you start counting the rooftops and stuff with so many thoughts. So that's why exercise is important. So I think the other aspects, you should avoid alcohol, smoking, exposure to radiation, and then find some time to go to the sunshine, because vitamin D, as I said on my stuff, vitamin D is very crucial for prevention of cancers. And then you should avoid infectious viruses like hepatitis, HIV, and human papilloma virus. You know, they cause cancer. And drink a lot of water, because we are 70% water.
Yes.
Thank you so much. I've just tried to smash all that together and then give you some insight. Thank you so much.
No problem. I would like to then start looking at winding up the show, what we call our parting shots. Before that, actually, I've got 3 questions I want to ask, and Salima has dropped off again. I want to ask very quickly. I just want to ask this question. First of all, Anne, why is Breast Cancer Awareness Month only in October? What's wrong with January, June, when I was born? Why is October so special?
I am not aware. I'm not aware of why October was picked, but it's very important to really focus on 1 month. It doesn't mean that, as I told you, for Prof. I and other people who work in cancer centers, cancer is every day. But you find that there has to be a purpose, and that is the reason why. And the whole year, the only months that don't have a cancer awareness is, I think, August and December. Like this month is pancreatic and stomach cancer, so that can be focused to that. Yeah.
Okay, that's something else we need to then pick up as a subject. Prof, very quick question for you. What are the survival rates for breast cancer?
Yes, so that's why screening is very, very important, because we know that if you get it in the early stage, like I said, if you get it stage 1 and 0, then the survival rates in 5 years to 10 years approach 100%. So long as the treatment was tailored to the patient's needs and that particular patient. So the survival rates are very good for early breast cancer. And early breast cancer extends up to stage 2B. It's just not one stage, 0, 1, and 2, up to 2B, where the lymph nodes are involved, but are not so many. Because the main advantage is that chemotherapeutic agents have really improved. They have really improved the outcomes of these breast cancers. But people who have stage 3 disease, they have, even after treatment, and I have so many of them, because you remember, as I said, they normally present late here. We have some that I've seen for the last 15 years, the ones who are stage 3. So what we did, we gave them chemo first, then we did surgery, and then we did other things, and they're still alive. In fact, we did a study with one of my residents recently, which we published in Annals of American Surgery, Surgical Oncology, and our recurrence rates or disease rates after treatment are basically only 7%, and the world over is between 7 to 15%. So we're doing very well if we approach it as a team, other than approaching it as one person, knowing it all to treat a patient. So stage 4 is the one that has the lowest, ranging from, depending on the subtype, the subtypes are already described, from 1 year to 5 years survival rates, and then from 5% to 10% survival rates in 5 years to 10 years. But I've also seen some of these patients with stage 4 who are treated well, going up to around 10 years. It comes and goes, and they're managed, so long as they're being managed properly. I hope that answers your question, sir.
No, yeah. Yes, it does. I'm sure it helps a lot of viewers as well. I need to wind up, so I'm going to start with ladies first. I wish Salima was here, so we could also get her view. But Anne, I wanted to get your parting shot. Anything you'd like to impart, anything you'd like to let the viewers know or leave them with? Yeah, please go ahead. It's been a very fascinating conversation, actually, but I just wanted to then get the final word from you.
Okay, thank you very much. What I would like to tell the viewers is that cancer does not mean death, and early detection means cure. It increases the chances of cure. I always tell my friends, women, my sisters, my mother, be proud of yourself, know your breasts. Walk around in your bedroom naked so that you see, you feel, and let your partner also feel them. Then for for pap smear, because cervical cancer is also increasing, on your birthday, even you, Joroge and Matu, you don't buy me a present. Just take me for a pap smear on my birthday and let me do it. If no one else can give it to me, then that would be my birthday present. Let us take care of yourself. Let us take care of ourselves. Let's love ourselves. Thank you.
Thank you so much, Anne. I was just listening to you, and I was thinking, some guys are going to look at their better halves. I call them better halves. I would not necessarily classify them as girlfriends or boyfriends or whatever the case may be. But that's probably one of the most interestingly, probably unromantic ways to say happy birthday or happy anniversary, but it is relevant, and I like the way you've put it. Thank you so much. That's really made my day. Professor, could I have your parting shot, please?
I kind of gave it to you already, but I think I can just repeat. I think that
right.
Yeah, we should focus more on prevention than curative. So we should all of us, men and women, try to do what we got to do to ourselves, what we usually do for our cars. Like, if you have a car, you have a comprehensive insurance, and do you know that comprehensive insurance doesn't cover you? It covers third party and repairs. Then you take it for service every 5,000 kilometers or 3,000 kilometers, depending on which type, whether it's diesel or petrol. So I think that seriously, for women after 20 years, they should go for clinical breast examination by the doctors. And those who are above 40 should go for every year. They should go for mammographic screening until they hit 55. And after 55, they can do it every 2 years. As men, we should go for PSA, we should go for colonoscopies, we should go for total checkup, including cholesterol, blood sugar, hypertension, ECGs, so that we prevent all these non-communicable diseases, because now that's where the current problem is lying. And avoid unnecessary alcohol intake. If you have to take it, take on red wine that has some proper preventive red wine, dry, maybe a glass in 1 week. Don't go and overdrink, and then do not smoke or stay closer to people who are smoking. And drink a lot of water, really. Take a lot of water, for 2 liters a day. The older you grow, the more that switch off is for the water thirsty. So you must force yourself to drink water or watery drinks. And then prevent infectious diseases like HIV, as I said, hepatitis B and C, and then human papilloma. And for those cancers that have vaccinations, we should go for vaccinations. For example, cervical cancer, human papilloma virus is a vaccine now, and we can vaccinate ourselves against hepatitis B and C to prevent cancer of the stomach and cancer of the liver. Thank you so much for having us today. And this will make our country a better place. And exercise a lot. Walk from point to point. Don't call people. Just walk there. And don't eat until you are hungry. Don't eat unless you are hungry, because you're going to develop unnecessary weight that causes a lot of problems. Thank you so much.
Thank you so much, Professor. It's been an absolutely fascinating conversation. Unfortunately, we lost Salima in and out of it, but you heard it from her. She was diagnosed with breast cancer, and she's managing her life. And yeah, it's been a really, really interesting and eye-opening conversation. Martin, I'd like to have your thoughts.
Thank you so much.
Yeah, I've been following. Very, very interesting. I've learned a thing or two. And we have Salima here. Let her first. Let her give us a parting shot before I say a thing or two. Salma, welcome back. Maybe you can go again, ask her question.
No.
Okay, we just wanted to ask you, Salim, what your parting shot would be, is in terms of something you'd like to impart on the viewers, any advice or anything personal that you'd like to then say. This is the kind of mark I'd like to live on today's show, and I want people to take away from watching today's show.
Yes.
So do you want me to repeat the question? Salima? Would you like me to repeat the question, Salima? Okay.
Yeah, there's connectivity issues.
It's unfortunate, yeah.
Yeah.
She's gone. So, Martin, you were saying?
She's coming back.
Oh,
she's coming back. Yeah, she's back.
She's gone again. Okay, so do you want to use what you were saying as a recap in terms of what you picked up from the conversation?
Yes, all very interesting. It comes out very clear. One thing that stands out is the early detection and prevention side of it. Early detection, which I like what Anne said, it's free when it's done by yourself, and you can do it as frequently as possible. Just be aware of your body. Learn to listen to your body. And I always say this. Same comes with cravings, food cravings. Your body actually, your body lets you know where things are. You have a deficiency in certain areas. You wonder why suddenly you have a craving for a certain type of food and so on and so forth. And if you learn to get that balance, listen to your body, you also get to understand that something is not right and requires maybe a trip to the hospital to get some tests. It's been lovely talking to all of you. Listening to Salma's experience has been interesting as well. I personally have gone through experience with someone very close, and I've seen both extremes. I've seen the defeatist sort of attitude. It's over, it's done. I'm just waiting, to meet my maker. And I've seen the other side of someone who says no, it's not over until I say it's over, and they just live their life and carry on, to the end. Of course, going through the various required treatments and visits, frequent visits to the, to the doctors and all. But it's just an attitude, a mindset. And for that, I have this for my parting shot.
Yes.
I'm just sharing it now. And basically, you can be a victim of cancer or a survivor of cancer. It's a mindset. It's what you want it to be, how you see it. So there we go. So to those watching us, it's been an interesting evening talk that I think is an eye opener. I think we should all encourage the people, our loved ones, to at least before the end of this year, go and just have a test. If you have never done it, start now. If you're a frequent visitor for testing, just keep at it, because it's as you've heard it from the experts here, early prevention, early detection makes one hell of a difference. Thank you for watching us live this evening. See you next week, same time. And bye. Thank you, Prof. Thank you, Anne.
Thank you, Anne.
Thank you, Aweru. And sorry that we've lost Salma to this, saying goodbye. But yeah, here we are. Thank you very much.
Thank you.
Thanks.
Thank you. Thank you, Prof.
Thanks so much.
Thank you.
Thank you so much.
Bye-bye.
Thank you. It was nice seeing you guys.
Okay.
Very
Yeah, nice seeing all of you.
Thanks for having us. Thanks for hosting us.
I need that coffee.